Greetings everyone and welcome to the Emergency Medicine Cardiology Course. This is Amal Mattu from the University of Maryland School of Medicine, and welcome. Well, this course is a fantastic course. It's a lot of fun, and we've been very successful in teaching this course to hundreds of emergency physicians in Toronto and Montreal over the past couple of years. And 2020 was going so well. We were looking forward to going back to Toronto and Montreal, and also heading to the western part of Canada, out to Vancouver, to teach the course out there. It's a 2-day course that covers a lot of material in electrocardiography and emergency cardiology in general. But as you know, COVID hit, and so we've had to convert to a virtual course. So that's what we're going to do. This fall, we're going to be conducting a virtual course, and we're going to be posting more details about the course at the website emcardio.com, so check it out. What exactly do we cover in this course? Probably about 60% of the course is focused on emergency electrocardiography, and about 40% on just emergency cardiology in general, acute heart failure, ACS updates, syncope, cardiac arrest, and new literature updates. But just to give you a little sample of some of the electrocardiography stuff that we cover, take a look at a few cases that we will discuss and a few themes, and test yourself and see how your skills stack up against what you will know by the time this course is over. Take a look at this. This patient comes in with acute chest pain, and as you can see, this patient has a left bundle branch block pattern. Most of us learn that you can't diagnose ischemia in the presence of a left bundle, but actually this is diagnostic of a particular finding, which predicts that this patient needs lytics right now or needs to go to the cath lab. We're going to talk about the Sgarbossa criteria. And by the way, if you know the Sgarbossa criteria, it doesn't work in this case. But there's some revisions of the Sgarbossa criteria that you need to know, which will help you get this patient to the cath lab. Why does this patient, who's only 24 years old, need to go emergently to the cath lab? What is it about his T waves which predicts he's got a proximal LAD occlusion? How about this patient? Take a look at these T waves. Those are some pretty ugly T waves, but after this course, you're going to know why these T waves actually represent a normal variant. So you're not going to waste your time sending this patient to the cath lab because it'll turn out to be negative. Speaking of more T waves, we're going to really get into the nitty-gritty of T waves in here. Take a look at these T waves at your computer, and probably most of your consultants are going to call acute cardiac ischemia, but the treatment here is actually not an ACS therapy. In fact, the national and international guidelines on care of patients with ACS is going to mislead you. This patient doesn't need fibrinolytics or antiplatelet medications. This patient needs something completely different that is completely diagnosable based on this 12-lead ECG. How about this patient? This patient has a no-brainer septal STEMI. And so you might be tempted to give this patient thrombolytics, but there's something on this ECG which actually tells you that thrombolytics are not going to work in this patient. The only way to treat this patient is in the cath lab, even if that potentially means transferring the patient. How about this one? This patient's got ST segment depression in a bunch of leads, and this patient, even with ST segment depression, needs to go right to cath. And the guidelines won't help you out here because the guidelines say you only take patients to the cath lab or give lytics to patients that have ST segment elevation. Here's somebody with ST depression everywhere who needs, nevertheless, to go right to cath, or this patient may have perhaps as much as a 70 to 75% chance of heading into cardiogenic shock and dying. Here's a 35-year-old who comes in with sharp pleuritic, maybe a little bit of positional chest pain, nearly died because the diagnosis was made incorrectly. Take a look at those PR segments. There's PR segment depression or downsloping in a few of the inferior leads and maybe out here in the lateral leads as well. So this, for all the world, looks like pericarditis. It's not pericarditis. This is actually an acute STEMI. We'll talk about why PR segments are a myth that we've all been taught that are predictive of pericarditis. They are not predictive of pericarditis. We've all been taught that myth before. How about this patient? His ECG is read as normal by the computer, and there's actually a subtle finding on this ECG that predicts that this patient is in the throes of an early impending inferior wall STEMI. Take a look at this one. Here's another patient who's got ST segment depression in a handful of leads. There's actually something on this ECG, which predicts that this patient has an acutely unstable proximal LAD occlusion and probably is best to go to the cath lab right now. And as a secondary finding, we'll talk about how you should be looking at T waves and QRS complexes and comparing the size of the T wave and the QRS complex in such a way that when the T wave and QRS complex are in a certain proportion, it is an outstanding predictor of early cardiac ischemia. So that's just some of the ischemia things that we'll talk about in the electrocardiography part of the course. What about the dysrhythmias? Well, here's a few to test yourself on with regards to the dysrhythmias part of the course. Here's a patient with an irregular wide complex tachycardia. And this patient might be borderline stable. We've all been taught that amiodarone works for everything. It doesn't work for this. If you give amiodarone to this patient is likely to die. We'll talk about what it is on this 12-lead ECG that says, don't give me amiodarone. How about this one? This patient has a regular, wide, complex tachycardia that your computer is going to call ventricular tachycardia. And it turns out, once again, amiodarone will kill this patient. By the way, so will lidocaine and so will procainamide. We'll talk about what it is on this 12-lead that says don't treat this patient. Take a look at this bradycardia. Huge sinus pauses on this bradycardia, and you might be tempted to try to pace this patient, and that's probably okay, but you know what? Pacing doesn't work with this particular type of bradycardia. There's something that ACLS doesn't teach you about bradycardias, and that's the only drug that will work on this particular therapy. What drug is that? Well, ACLS isn't going to help you out here. How about this one? This patient has a right bundle branch block pattern and a left anterior fascicular block, but take a look at the rhythm down there at the bottom. You'll notice that there are P waves that are not being conducted. So you've got some type of AV block. The PR intervals are all staying the same, so clearly this is a Mobitz 2, and so you're going to want to probably pace this patient. It turns out that pacing not only doesn't work, but is totally not indicated for this patient. In fact, this patient probably just needs a little touch of an oral medicine, and then it can go home back in sinus rhythm. How about this one? This was a confusing one to a lot of people. The patient's got atrial flutter. So the atrium's going too fast. The ventricle is bradycardic, so the ventricle's going too slow. Atrium's going too fast. Ventricle's going too slow. Do you shock them or do you pace them? Most people end up choosing the wrong therapy. And then take a look at this one. This is a patient who had a cellulitis who was simply waiting to be admitted to the medicine service and suddenly developed this rhythm. And the monitor is helping you out here, calling this ventricular tachycardia. The patient got started on amiodarone and admitted to the CCU for this run of presumably polymorphic VTAC, and it turned out it was a wasted CCU admission. This patient has nothing. This patient didn't need amiodarone or a CCU admission. The patient just needed antibiotics for the cellulitis. This is a nothing rhythm that you don't have to worry about, and we'll talk about why that is. So this is just a sampling of some of the things that we're going to cover in just the electrocardiography portion of this course. Again, probably about 60% of our time will be spent talking about ECGs, and the other 40% we'll spend talking about a multitude of other general emergency cardiography topics like heart failure, updates in ACS, and other literature updates, and so on. So again, check out the website, www.emcardio.com. Don't settle for knowing the basics. If you want to save lives, it behooves you and your patients to know a little bit more than the basics, and we're going to take you far beyond the basics with what we talk about in this course. Hope to see you there.